Okay, there might be a few more people coming in, but we will make a start. Just want to say welcome to everyone to the official launch of the Framing Sexual and Reproductive Health Message Guide. Thank you so much for taking the time out today to come along to this. It's been so encouraging to see the huge amount of interest in registrations and discussion about this guide so far. And we're always really encouraged by the idea of so many people talking about sexual and reproductive health. I'm Sarah Lorrimar. I use she, her pronouns, and I'm the team leader of sexual and reproductive health at GenWest. I'm going to be the host for today's event, and I'm really looking forward to presenting all of the wonderful research and the guide and all of the presenters that are talking today. Before we do begin, I would like to start with acknowledgement of country. So on behalf of the Victorian Women's Health Services Network, I'd like to acknowledge the traditional owners and custodians of the lands and waters on which we work and live across Victoria. For me today, I'm dialing in from the lands of the Wurundjeri people of the Kulin Nation and would like to pay respects to elders past and present. We recognise that sovereignty was never ceded and that we are the beneficiaries of stolen land and dispossession. We know that this began over 200 years ago and continues to happen today. And as a collective of women's health services, we are committed to collaboration that furthers self-determination and creating a better future for all. Just going to run through a little bit of housekeeping for today, letting everyone know that today's webinar is being recorded, although your microphone and camera are switched off. If you would like to contribute to the conversation, the chat option is available to everyone. And there will be a Q&A session after the presentation. So if you have any questions that you'd like discussed by our panelists, please pop them into the Q&A function. We also have closed captions enabled, and the message guide is going to be made available to everyone. We'll send it out via email. It's also going to be available on the Women's Health Services Network website and the Common Cause website as well. And today's recording will be sent shortly as well. All right, a bit of an overview of what today's event includes. So we'll be hearing from Tilly Mahoney from Women's Health in the North, providing an introduction to the project. And then we'll be hearing from Kate and Mark from Common Cause Australia, who are going into the research overview and top tips into the development of this guide. And then we'll close with a Q&A session, hearing from Kate and Mark, as well as Shannon Hill from Women's Health Grampians. Before we do dive into all of that though, I wanted to give a bit of context as to who the Victorian Women's Health Services are. So we're a collective of 12 state government funded women's health services, each a centre of excellence in gendered health promotion, primary prevention and gender equity. We use evidence-based research to support legislation, to support policy, deliver programs and healthcare services that ensure women and gender diverse people stay well. This is just a bit of a visual to show the different regions that we work with in across the state, and also a list of our statewide women's health services that do work across the whole of Victoria. All right, without further ado, I will introduce you to Tilly Mahoney, who's a Sexual and Reproductive Health Coordinator at Women's Health in the North.
Thank you, Sarah. Firstly, welcome and thank you for joining us for today's launch. My name's Tilly Mahoney. I use she, her pronouns, and I am the coordinator of sexual and reproductive health at Women's Health in the North. I'm speaking to you today on behalf of the team behind Framing Sexual and Reproductive Health. Before I begin, I'd like to acknowledge the Wurundjeri people of the Kulin Nation as traditional custodians of the land that I'm on today, and pay my respects to elders past and present. I extend that respect to all First Nations people also joining us on the call today. So I'm going to give you some context as to what led to the creation of this message guide, talk a bit about how it supports prevention and help seeking, and about how it can contribute to cultural change across Victoria and beyond. So it's not news to anyone that communication is important. Communication of quality, evidence-based information is the foundation for informed decision-making and autonomy. It has the power to guide us towards appropriate support and services, to seek help when we need it, and to advocate for ourselves in health and public settings. But quality and evidence-based information isn't necessarily enough. We need to be thinking not only about what we're communicating, but also about how we are communicating it. Are we engaging people, or are they scrolling past our content? Are we building confidence in our audience, or are people zoning out? Sorry. Are we unintentionally reinforcing shame and stigma through the language that we use? How do we know that our communication is effective and resonating with our communities? These are the questions that led to the development of this message guide, Framing Sexual and Reproductive Health. Within the broader social and political context, we need to be able to cut through the noise and communicate about how sexual and reproductive health issues are framed in a way that builds people's confidence to talk about it and to seek support and services when they need to. Sexual and reproductive health can often be overlooked as something people can make sense of themselves, that people can navigate without support. But in reality, navigating sexual and reproductive health can be really challenging for many reasons, including a lack of clarity in the information available to us. Health promotion information can tend to be jargon heavy, and sometimes our familiarity with the sexual and reproductive health space can get in the way of considering how information might be perceived from a community perspective. That being said, we need evidence to guide the way we articulate ourselves, to clarify information and build collective understanding among community. What we name and how we frame sexual and reproductive health issues affects what people notice and what they care about. Our language and our framing can influence attitudes and beliefs, and in turn, people's actions. So through effective and persuasive messaging, we can drive cultural change. As language evolves, so do the beliefs and values it conveys. So we need to think deeply about how we're communicating and how this could be shifting how people think, feel, and act. To be very clear, this work isn't about which exact words to use, and it's not only about social media as an environment, although that's a space that we can certainly apply the learnings. What we're talking about is how we frame the conversation in a way that meets people where they're at and brings people on board towards a future free of stigma, shame, and misinformation relating to sexual and reproductive health. So why are we working in this space? The Victorian Women's Health Services Network takes action to address the attitudes, systems, and structures that contribute to unequal health outcomes. Part of this involves giving people the information and supports needed to make positive, informed choices about their health, and empowering communities to have more ownership and control over their health and health services. As part of the Women's Health Services Network's role, we drive delivery of the Victorian Government's Women's Sexual and Reproductive Health Plan. Among a broad range of priorities and action areas, reducing stigma is consistently raised as a focus. This is also the case for the accompanying strategy overview and system enabler plan. So when it comes to stigma, shame, and misinformation, open communication is one of the most powerful tools that we have. We know that stigma and shame can create real barriers to care for community members, and we know that the shame and stigma that can surround sexual and reproductive health disproportionately impacts women and gender diverse people, making them less likely to seek support and services. The recommendations in the resource that we've created seek to support sector-wide consistency and impact, to counteract unsupportive narratives, and to build community confidence to talk about sexual and reproductive health and to seek support. And maybe the recommendations in this guide confirm that what you are already doing is on the right track towards this. The guide is a practical tool. It helps us communicate in ways that are strengths-based and aligned with the values that move people to care about the issue and to act. This work also sits within our broader efforts to support gender equity, as we know that poor sexual and reproductive health outcomes are both determinants and products of gender inequality. I'm going to pass back to Sarah now, as I'm sure everyone's eager to hear from Common Cause, but I hope that lays out some of the thinking and groundwork leading up to this project. Thank you, Sarah.
Thanks, Tilly. All right, I'd like to introduce Mark Chenery and Kate May from Common Cause Australia. They're going to do a bit of a deep dive into the research and all of the excellent work that went into the development of this resource, as well as talking about top tips on how to implement it in your work.
Great, thank you, Sarah. Good afternoon, everyone. So I'm Mark Chenery. I am the co-founder and director of Common Cause Australia. And what I'd like to do first is present to you a few key concepts that underpin our approach to communications, which inform the type of research that we did for this project, as well as the type of insight. So I'll give you a good background to why we are suggesting the things that we are suggesting today. So one of the first and most important concepts that I want to share with you is, well, maybe something that you've noticed already, and that is that human beings are not necessarily rational, at least not most of the time. So cognitive scientists estimate at least 95% of human thought happens below the level of conscious awareness, which means that most of the thinking that we do, that our brains do on a daily basis, is not accessible to our conscious reasoning. And most of the decisions we make are based on how we feel about the gut options before us. So some options are going to feel more right than other options. And what we tend to do is, whether it's a small choice like what to have for breakfast or what to wear that day, or maybe who to vote for, or whether or not to talk to someone about a sexual and reproductive health issue, these decisions are driven far more by what feels most right. So we go with the option that feels most right, and then we ignore the options that feel less right or perhaps even feel wrong. And that is how we make most of our decisions, at that gut level. So if we want to understand how to motivate people, how to change how people think about these issues, it is really important that we dive below the surface of what's happening inside people's brains as they think about this issue, because the vast majority of our thinking is sort of below that surface level. Now, one of the things that influences how we feel about the different options before us in any one moment is the perspective that we are taking on an issue in any moment. And so what you're looking at here on the slide is a visual illusion. And have a look at it and kind of see what you can see there. You should actually be able to see eventually two different things. On the one hand, it's a duck. On the other, it's a rabbit. Now, this is a 100-year-old visual illusion called the duck rabbit, and it illustrates a really important concept in cognitive framing, which is one of the key disciplines that underpins our approach to communication, and that is of biconceptualism, the ability of the human brain to perceive the exact same thing from multiple different perspectives. And this is actually quite a revolutionary concept in communications when we realize the full implications of it. Because there is a very, very common piece of advice that you've no doubt heard a communications expert or other tell you. You may even have given other people this advice yourself, and that is that we must meet our audience where they're at. Now, this is good advice from the perspective of relating to your audience. The more that we understand about our audience, the better that we can connect with them. At the same time, it's hugely misleading advice if we take it to mean that there's a fixed place where our audience is at, where we must meet them. Because most people can think about most issues from multiple different perspectives. So our job isn't actually to meet our audience where we assume that they're fixed at. Our job is to take them to where they're capable of going, and making sure that we choose a location in which we're going to have the most productive conversation possible, where at the end of the day, people feel at a gut level like what we would like them to do or what we think might be best for them feels most right to them as well. One of the ways in which this biconceptual concept influences how we do our research at Common Cause and the way we approach this particular project is the way in which we think about audiences. because on any issue, there's going to be multiple different audiences with various levels of biconceptualism. On the one hand, you've got our base. These are people who agree with us. So they agree with us about the problem, they agree with us about the solutions. And what makes them quite unique in our analysis is that they're not particularly biconceptual on this topic. On this topic, they're quite fixed in their perspective. And that's great, right? Because it means they already agree with us. And if anyone came along to try and convince them otherwise, they'd struggle to change their minds. On the other hand, typically we've got another group of people out there, and often we call them the opposition. And these are people who disagree with us. They disagree with us about the problem, maybe because they don't think there is a problem, or maybe they think there is a problem, but it's caused by something other than what we think it's caused by. And as a result of that, they do not support our solutions. And in fact, when we talk about what we think should happen, it makes our opposition feel quite negative at a gut level. So it feels really wrong to them. But in between, there is a whole bunch of people that absolutely can think about the issue from multiple perspectives. And these are what we call the persuadables. These are people who, if we frame the issue well, can see it from our perspective, and then the sort of changes that we want feel right. But unfortunately, they can also see the issue from an unhelpful opposition perspective, in which what we're asking for feels less right. And so the key thing that we need to do most of the time in our communications is really focus on this persuadable group of people, the people who we can actually reach and influence. And what we're doing is toggling them into a helpful frame of mind while avoiding activating unhelpful frames. Now, one thing you'll notice when my colleague Kate presents the results of our specific research on this is that we haven't gone with this naming of the categories for good reasons that she will elaborate on. Now, one other concept I want to chat to you about quickly before Kate gets very specific in what we found is values. So one of the most effective ways of motivating people and changing how they feel about issues is to connect with their values. And we know that connecting with people's values, or which values we connect with when we're communicating, has a really big impact on how people are likely to think and act as a result. And through 3 decades of peer-reviewed research, as well as our own message testing here in Australia on a range of different topics, we know that there are 3 groups of values that are most effective and persuasive to engage when it comes to health and health promotion topic areas like this. First one is self-direction. So self-direction values includes things like choosing my own goals in life, freedom, independence, creativity, and curiosity. It's all about being allowed to sort of carve your own path in life rather than necessarily following the path carved for us by others or sort of set for us by others. Then there's universalism values, which is about realizing that we all have equal value and all the principles that would emerge from that. So things like equality, social justice, broad-mindedness, but also thinking about the value of things beyond human beings, so protecting the environment and unity with nature. Then there's benevolence values. Benevolence values are in-group altruism values. They're all about thinking about the needs and welfare of people beyond ourselves, but limited to those in our social circles, so those with whom we have relationships. So our friends, our family, our neighbours, our community more broadly. And that includes things like honesty, loyalty, responsibility, love, friendship, and many more. So activating any of these values in our messaging consistently brings out more pro-social and environmental attitudes and behaviours, more accepting attitudes and behaviours, and less discriminatory attitudes and behaviours. On the other hand, what we know is engaging an opposition set of values, achievement and power values, has the exact opposite effect. So when you appeal to people's sense of competition, achievement, winning, intelligence, capability, success, power, authority, wealth, or status, these kind of messaging appeals are likely to bring out the exact opposite types of attitudes and behaviors, more antisocial attitudes and behaviors, more selfish, competitive, antagonistic behaviors and attitudes. People are more likely to discriminate against outgroups as well. So we know from a whole bunch of research, people are more nationalistic, homophobic, sexist, racist, ageist, you name it. If there's an ism, this is brought out by engaging these values. In addition to that, finally, security values. So we know that if you scare people using fear-based messaging, it tends to activate our security values, which tends to then bleed over into our power and achievement values and have the same kind of effect on our attitudes and behaviors, bringing out those more antisocial and environmentally destructive attitudes and behaviors. So we have found in our messaging, in our message testing in particular, and in this project as well, it is particularly effective to avoid these fear-based, status-based, achievement-based values, and far more effective to lean into those yellow and green values, those self-direction, universalism, and benevolence values. But I think that's all I'll say about our methodology at this point, and I'll pass over to Kate to get into the details of what we found in our research and how we went about it.
Thanks, Mark, and hi everyone. I'm Kate from Common Cause Australia. I'm going to spend the next half an hour or so really diving deep into this project, sharing the overview of what we did and our methods, and really spending some time diving into our key top tips and practical implications for this work. Ultimately, we decided this project should be about how we can make people feel more comfortable talking about sexual and reproductive health and seeking services and feeling confident seeking services when they need to. We looked at this project with the general population in mind, really interested in women, but not exclusively. And we also considered public organisations and policy leaders and how we can make them feel more comfortable and confident talking about sexual and reproductive health too. For this project, we considered sexual and reproductive health more broadly, encompassing all the diverse topics that sit in the space. We did look at some subtopics throughout this, such as abortion, STI testing, consent, pleasure, but we wanted overall these tips to be encompassing of sexual and reproductive health as a whole. I'm going to talk you through the process and the methods that we did throughout this project. We started off with a scoping piece, looking at what literature, grey literature, and public communication guides were available on sexual and reproductive health and some of those subtopics I alluded to before. We also ran a stakeholder workshop to really try and unearth some of the assumptions and thinking and gaps in communications within the sector to really help consolidate our research direction and what we wanted out of this project. Once we'd really set that direction, we did a big discourse review, looking what's said in the public, what's in the public sphere about sexual and reproductive health, and how are people talking about these issues. We looked at 60 sources, and this was a mix of media, social media, public websites, policy, advocate discussions as well. And we analysed and coded how people were using language, how they were using narratives, what was coming up as these key topics, what was missing. We looked at values, as Mark mentioned to before, which is really important. And what were these frames? What were people talking about? Who were people talking about? And what was missing? We really wanted to do this to try and answer the question, how do people in the public talk about sexual and reproductive health? And how can we shift things to be a bit more comfortable and confident when it came to sexual and reproductive health? From here, we wanted to test out how we could shift things, how we could move things in a more positive direction, or consolidate, what works well and what perhaps doesn't. We certainly had some unanswered questions, and this was where we used the dial testing to really consolidate that. So this was a 15-minute online survey. This was nationally representative, so we source respondents based on a split of age and demographic location. It was about a 50-50 split when it came to men and women. And a quick note for a limitation of this study, we actually didn't pick up any people that were trans or non-binary. And as such, this survey just didn't pick up on that population in this size. And it is a limitation and something that can be explored later on. But a bit more about the survey. It included a mix of agree or disagree questions to key issues in sexual and reproductive health, and some policy statements as well, and whether people feel comfortable and confident talking about different issues. We also did some split sample questions where 50% of respondents receive one type of question or one framing, the other 50% receive another type, and we see what happens, and we see where we can get some really positive responses and what the difference is. We also did 5 30-second audio messages. These are where participants can dial up or down on a dial how much they agree or disagree with a message, an audio message in real time. So we get some live feedback as when people sort of nodding along, agreeing, or when they dip down and disagree, which is really interesting, and we'll share a couple of them as we go on. And then the last stage of this project, which was my favourite stage, we ran a series of focus groups. So 4 90-minute groups. And this was a chance to really dig deeper into those findings. We had some things that worked well in the dial testing. We wanted to consolidate that and see how we got some qualitative feedback on that as well as the quantitative data. We also wanted to learn a bit more about a priority population, as we know that there are some differences in demographics and some subpopulations that we want to learn a little bit more about. I was really ummed what we were going to do with this one set of focus groups. So we ended up looking at people from lower socioeconomic backgrounds. We chose this population because there were some signs in the dial testing that there was a bit more resistance amongst people from lower socioeconomic backgrounds. And we wanted to understand that a little bit more. We also wanted to, dig down into some of our assumptions about cost as a barrier and how that maybe came into play and whether that impacted our messaging. I guess there's really a hypothetical 5th stage with this project. There's so much that we learned and so much more we can learn by talking to more populations and people on the ground. So we definitely encourage in our message guide to go out and run some focus groups of your own or discuss in your communities as well. And we provide a template for how we did this and how we screened for diversity and those sorts of things. So we can certainly go out and continue these findings, particularly of some of the subpopulations that we didn't pick up much data in a nationally representative format. All right, so I'm going to spend, the next slide. I'm going to explain how we broke down this, the nationally representative survey into attitudinal groups. As Mark alluded to before, a common cause for most of our projects, we often have our supporters, our persuadables, and our opponents. This is particularly a good grouping when it comes to policy issues or understanding, how the public thinks and feels about things. Because the purpose of this project was understanding how making people more comfortable and confident in seeking services, I guess the phrasing opposition and supporter didn't quite work. So the way we did this for this project was to look at the responses to the questions and divide people based on whether they were enthusiasts, persuadables, or resistors. I'll explain what I mean by these groups. Our enthusiasts are people that strongly believe that everyone should talk about and be able to access sexual and reproductive health without stigma, shame, or barriers. Not only do they believe that, they're also really confident with talking about sexual and reproductive health issues in their own spaces as well. On the other end of the scale, we've got our resistors, and these are people who view sexual and reproductive health as more private or even a bit more taboo. We don't need to be talking about this publicly. They're not comfortable with discussions in the public sphere, and they're certainly not comfortable with talking about sexual and reproductive health and seeking services when they need to. This is only 9% of the population compared to 21 of our enthusiasts. So it's always promising that that's a smaller cohort. But most people are our persuadables, which sit at 70%. And they were the people that, often agreed with sexual and reproductive health as a good thing for us to talk about in society, but perhaps they weren't comfortable in doing it themselves. Persuadables are also people that can agree with enthusiasts and agree with resistors. They answer our questions differently and they can flip-flop around the place. Because of this, these are really our key target audiences for our messages, because we know we can win them over, and with the right type of framing, they can think like enthusiasts do, feel more comfortable and confident. So throughout our study, we were really looking at how persuadables responded and how we could get boosts in overall support. There are some demographic breakdowns in this and some slight variations with some demographics. I'm not going to talk to them or I will definitely run out of time, but this is available in the message guide and we can come to it in the panel discussion if there's any particular demographic difference that the audience would like us to dive into. But I do want to spend the rest of my time walking through the top tips for this project. And this is something we came to as a group when we're working through all these different methods and stages. What are our practical takeaways? We've got some evidence behind that we can give people that work in sexual and reproductive health the confidence to talk about sexual and reproductive health in ways that do increase people's comfort and confidence in talking about SRH and seeking services. So I'm going to present the 7 top tips. Hopefully I get around to time to present all of them. And this is really the key bit and what we provide in the message guide that's being launched today. So the first one I want to point to is how we shape this narrative of sexual and reproductive health and seeking services and talking about it. And that is to point to outdated ideas that create stigma and discomfort as the core problem here. We really played with how we can frame the barriers and solutions to some of the issues we face in sexual and reproductive health communications, and ultimately came to this idea that stigma is a really powerful story. But there are different ways we can talk about stigma, and we know that stigma is not immovable or fixed. It's something that has really changed over the course of years, and lots of great work has been done in sexual and reproductive health. So what we wanted to do here is to show that stigma is something that's external, and we can break down that concept by showing it's a product of social norms rather than something intrinsic or inevitable. It invites people to this sense of possibility that stigma and comfort can break down, it can move and shift over time, and there are things we can do collectively. So we really say point to outdated ideas here and explain a little bit more what we mean when we say stigma, because it helps it sort of move and helps us feel more engaged and excited about how we can progress. So I'm going to show a data point for this, and this is pulled from the survey data. So what you're seeing on screen here is a data point, and this was a split sample question that we gave our audiences. So 50% of people received no priming statement, just a simple agree-disagree statement that says, I want to have more open discussions about sex and sexual health with people around me to normalise these important conversations. When we asked that question, we got some people agreeing, some people disagreeing. But what happened when we gave the other 50% of our cohort? We gave them a priming statement that said, many people feel that stigma and shame around sex and sexual health come from outdated ideas that discourage conversations about important health topics. When we gave this simple, small priming statement, breaking down a little bit about what stigma is, we actually got an 8% jump, which is a statistically significant jump in people's agreement that they want to go out and have more important conversations. We found this consistently across our project, that when we explained where stigma can come from or talked about it in a little bit more explanatory terms, we could get a nice boost in overall support for the things we wanted to see. So this is a really powerful narrative. What I'm going to show you here is an example of one of the dial messages that we tested. So you're going to see some lines move across the screen that show real-time feedback with our survey participants on how they responded to an audio message about stigma. So what you're going to see shortly is 3 lines. You'll see a red line for our resistors and how they respond to it, a green line for our enthusiasts, and an orange line for our persuadables. Now, what we're wanting to see here is our enthusiasts, their line going up, they're agreeing with what we're saying. We want to see our persuadables also going up and agreeing, not as much as our enthusiasts, they're not quite as on board, but we want to see them following a similar trend. And our poor resistors, we do want to see them, or we expect to see them going slightly the other way. They're not following the same trend, and they're not thinking about this issue in the same way. So I'm going to play the message. Hopefully the audio and everything comes through okay, and then I'll talk about it.
When someone has a concern about their health, it's important that they feel comfortable to talk about it with a trusted healthcare professional. But stigma, shame, and taboo within our communities about sex and sexual health can create barriers to seeking help about important concerns like pain during sex, contraception, or testing for sexually transmissible infections. These barriers are often rooted in outdated beliefs and social norms. As a result, many people feel uncomfortable reaching out for care, which can ultimately harm their health. The good news is that we can break down these barriers by talking about and normalizing sex and sexual health. By encouraging and engaging in honest discussions within our communities, workplaces, and social circles, we can make a meaningful difference.
Okay. So what you will have hopefully seen there is our enthusiasts nodding along and dialing up over as their message is explained, and our persuadables following a similar trend, just a little bit lower. And again, you will have seen our resistors not really feeling comfortable with what we're saying. We particularly lost them when we finished off the message by saying, we can break down these barriers by talking about and normalizing sex and sexual health. I don't think they were on board with that. But other than that, it was a really powerful message that people were dialing up from, and that's what we wanted to see in this project. Here's a few quotes that I've pulled from our focus groups. This is where we got to have a really rich discussion about stigma and break it down a bit more. When we were talking about some topics that maybe carried some discomfort, we would ask participants, where does this discomfort come from? You know, what's going on here? And we got a variety of answers. There's no one single source of stigma or discomfort or misinformation or things like that. Here are a few examples. We had people talking about gendered norms, things like sex being dirty and clean women and some of those things. We had a lot of talk about how these things can be passed down through generations, which was really interesting, and family dynamics. For some people, these things might be seen as shameful. And unfortunately and unsurprisingly, we did have a lot of discussion about the vocal minority of people, particularly in the abortion space, that have stigmatizing and discriminatory views. So people are very aware of that stigma and judgment. And for some people, that is quite confronting, and they might see going to a sexual and reproductive health service as a space that they could be judged. And that was certainly there when it came to these topics, not just abortion as well. So stigma is such an interesting thing, and it was so interesting to dig deep in it. But ultimately, we know that these things can shift and change, and we are part of this broader movement that's changed over time and hopefully will continue to grow and empower. So a simple messaging tip here, you could go from saying things like, there are a lot of shame and stigma around sexual and reproductive health in society, to breaking it down a bit more and explaining what that means. Outdated beliefs about sex leave some women feeling uncomfortable to speak up and access support when they need to, is a slight messaging shift we could do there. Okay, my next point, and this leads in really nicely from the first, how we sort of end a narrative where we talk about shame or stigma or taboo. The best solution that we can present to that we can offer our audiences is to encourage more open conversations about sexual and reproductive health and explain why they matter. This was a really powerful solution, and throughout the survey and focus groups, we found people responded really well to these sorts of framing. Interestingly, people were more on board when we encouraged more open conversations in communities or society. They're a little bit more resistant when we ask them to go out and have these conversations themselves, but it was still a really winning narrative. I'm going to show another data point to explain this. This was another split sample question. So 50% of people received a statement that said, talking about sex and sexual pleasure helps us be more informed and confident, so we choose to talk about it more with other people. The other 50% received a priming, that was the priming statement that some 50% got, and the other 50% received a statement that just said we should talk about sex and sexual pleasure with other people. They both received a definition about what we meant when we say sexual pleasure, but the difference was 50% had a statement about being more informed and confident. The cohort that received the statement about being more informed and confident, so showing why it matters to have these conversations, they had a boost of 15% overall and 19% for our persuadables in saying that we should talk about it more with other people. That's a huge boost, and particularly on a question about sexual pleasure, which was the hardest topic to shift people on, or the topic that had the most discomfort when we talked about sexual and reproductive health. So that was a huge boost, and why this was really our winning narrative. Lastly, I'm going to give us a quote on this, and this was a really lovely quote from one of the participants in the focus groups. The great thing about focus groups is sometimes you get these beautiful quotes that just sum up your overall project so nicely. And this person said, we should discuss it with our near and dear in a way we are creating awareness by talking about it and breaking the stigma. the more we talk about it, the more the taboo or the shame is being broken because it's just a normal topic. So really put really well, and this idea of it just being a normal part of our lives was really lovely. So some top tips here, going from saying sexual and reproductive health should be more open and freely discussed without shame and stigma, to by talking about sexual and reproductive health, we break down stigma and build strong channels for communication and support. Some other examples you could use to explain why these conversations matter include building confidence and comfort, encouraging people to seek care when they need it, helping boosting our health and preventing disease and things like that. So really explaining, it's not just enough to say on its own, we need to talk about sexual and reproductive health, but when we explain why and some of the positive benefits we can get from it, it definitely feels more motivating and exciting. So my next tip is to avoid negation and myth busting. I'm going to explain a little bit about what negation and myth busting is. Negation involves repeating a claim or an idea while trying to deny it or contradict it, often by adding the word not. So an example that we pulled from the discourse is wanting pleasurable sex is not something to feel embarrassed about. A very great and well-meaning statement, but what we've done there is put this concept of pleasurable sex with this concept of embarrassed, and we're pairing it together. Even though we put a not in the middle, we actually are building the frames and associations that we have in our minds of those topics. Myth busting is quite similar, and again, it's quite a common thing to do. It involves highlighting common misconceptions and then attempting to correct them with evidence. So an example is, one of the biggest myths about STIs is that if you don't have symptoms, then you don't have an infection. The reality is X, Y, and Z. Now, when it comes to myth busting or negation, again, it's well-meaning, but we're pairing these ideas together and giving them strength over time, often giving a lot of attention to oppositional ways of thinking, such as wanting pleasurable sex can feel embarrassing, or the myth about STIs. So a better alternative is to not do that and instead talk about what's true, what the facts are, and really build a positive frame around that. One tip I have around that is, instead of saying the negative thing that you don't want, what's the positive thing that you do want, and highlighting that as a frame. This was really hard with stigma as the topic that we sort of dove into, because we wanted to talk about stigma and break it down, but we didn't want to, I guess, reinforce it or draw too much attention to it, as we know it's not inherently a part of sexual and reproductive health, and many people confidently engage in sexual and reproductive health as they need to without feeling that sense of stigma or taboo. And we really played in this in the focus groups as well, and got some feedback that some of our messages that really talked about it heavily were maybe overemphasizing it or lingering on it a bit too long, and it didn't quite feel accurate to some people's experiences, or it also felt like this was worse than it is, and we didn't want to do that. We wanted a nice positive message to break down these ideas. So you'll see this quote on the side here. I'll read out a section of it. On a broad scale, we have to stop saying it's taboo, because when we say it's taboo, we make it taboo. And I think that was a great summary. So we want to talk about stigma and how we can break it down when it's at play, while acknowledging that it isn't everywhere, it's not for everyone, and it is something that shifts and moves as well. So yeah, that's an important consideration when it comes to negation and myth busting and talking about these sorts of things. I'll give an example on how we can do that. We can go from saying, talking about sex and sexual health is not something to feel embarrassed about. And there we've got the negation of saying not, but unintentionally pairing sex and sexual health with embarrassed. We could shift that to instead saying, talking about sex and sexual health with people you are comfortable with, build your knowledge and confidence. So instead of saying more of the bad things that we don't want, this is more of the good things that we do want. Okay, my next top tip is to create safe and respectful spaces. Interestingly, across this project, people generally agree, including Persuadables agree, that we should talk more openly about sexual and reproductive health and some of these subtopics we explored, but they're not necessarily comfortable doing it themselves, and we saw that across the board. There are also some topics that are more uncomfortable with others. I alluded to pleasure as one of the more difficult subjects to get the general public on board with. It was easier to talk about things like periods or STIs in some circumstances. Pleasure was a really funny one because some people just loved it, and we found it in the focus group. Some people, it just hit them at their right time in life and they were super engaged and on board. Others found it kind of weird, like a little out of place, or even didn't like it. It didn't sit with what was their sort of situation at the time. So I'm going to show a message about that later on. But I think as far as creating those safe and respectful spaces for those conversations, it really sometimes comes down to individual factors and relationships that determine where people seek support and where they feel comfortable. This focus group participant summed this up quite nicely. They said, I think the conversations people find most uncomfortable are about things like recurrent miscarriages, abortions, painful sex, menopause, discharge, painful periods. Even in safe spaces, these topics take time to come up. There needs to be a strong relationship first before people feel comfortable discussing them. So yeah, that really showed the strength of that, having relationships and safe spaces. So what I'm going to do now is play the message on pleasure, and we'll see what happens.
Enjoying life, exploring what feels good, and living with a sense of freedom and curiosity are key to a fulfilling and healthy life. For many, this includes exploring personal sexual pleasure, which involves safe, consensual, and enjoyable sexual experiences. Yet some people still see sex and sexual pleasure as taboo subjects that we're not allowed to discuss openly. This discomfort can prevent us from fully exploring enriching experiences and building deeper connections with ourselves and others. That's why it's important to talk about safe and enjoyable sex with friends, family, and peers where appropriate. By embracing and normalizing these conversations, we can foster understanding, reduce stigma, and celebrate an essential part of the human experience.
So overall, it was quite a successful message. We had our persuadables following a similar trend of agreeing as our enthusiasts did. But some interesting things happen there. You will have seen, firstly, our resistors feel very uncomfortable when we start saying it's important to talk about these things with people around us. And I don't know if you will have been able to see it, but what actually happened with our persuadables is as soon as we said it's important to talk about safe and enjoyable sex with friends, family, and peers, we had this little dip. And that was really interesting. And we played around how we encourage people to talk about these things and with who. And that piece of friends, family, and peers works for some people where that's a safe space. But for others, maybe they wouldn't talk about it with their friends. They'd only talk about it with their doctor, maybe the other way around. Some people, absolutely, they'll go to their mum or their sister, but God, are they going to have to go talk about these things to their uncle or their granddad? Or it evoked these sorts of conversations of discomfort. So that's why we put a little red mark on those words in the script we have there, we lost support with that, and we don't want to do that. So we eventually came to this conclusion, and I'll show you that in this top tip here. Instead of saying it's important to talk about sex and reproductive health within our communities and families, or just broadly saying it's important to talk about it, we can say it's important to have a safe space and someone you feel comfortable with to talk about sexual and reproductive health when you need to. So just a shift there in highlighting safe spaces and strong relationships. I even think someone in one of the groups brilliantly said, it doesn't matter, where you go to or, what you do, just having someone that you can go to talk about these things is really important. And interestingly, a little bit more data for you, when we did ask people where they would go to talk about these things or seek help, it was most commonly female friends and GPs were the two big leading places people felt most comfortable to go to. And one more point on create safe and respectful places. So we can highlight this in our communications, and that's one top tip. But the other thing we can create those spaces ourselves. And that's something that the Women's Health Services and people that work in sexual and reproductive health do so well. We really found this in our focus groups. Just by creating this space and giving people a social license to talk about these topics, people just opened up and had such rich, lovely conversations, and we really noted that and think that it's something we can do as well as delivering a message. We can also create those spaces ourselves. All right, couple more tips to get through. Keep it conversationable and relatable. Connection is really key with this topic. People connect with sexual and reproductive health in a very human way. It's a human experience across the life cycle. And people connect with the shared everyday experiences, not jargon, not medical language, not political language, but just everyday conversations. Messages that felt warm, friendly, and inclusive of different ages, life stages, communities worked best. People really looked for inclusivity too. There was this sense that SRH is for everyone, which was really nice, and it was important that our messages reflected that. I've just got a bit of feedback up on a screen from our focus group, and this was some negative feedback to one of our messages that they thought was too wordy. It just kept going on. It's all concern, problem, uncertainty, drones on with no real connection. It just lists services. It doesn't feel specific or engaging. And we did consistently find that if people felt the message was from a medical booklet or was too political, too jargony, then they didn't connect with it and they started to feel a bit more uncomfortable. So this was a real opportunity to just be relatable and use everyday language. So just a to and from. I'm not going to read this all out because it is a long one and it feels a bit jargony. But instead of giving, a firm, formal definition of sexual and reproductive health and your issue and using those sorts of political or sector language we might like to use, or perhaps medical and clinical diagnostic terms, instead talk about sexual and reproductive health or the topic that you're talking about in everyday language about, SRH is about making choices about relationships, sex, feeling comfortable and safe and supported doing so, those sorts of things that are more relatable and down to earth. So I've got a couple more tips to get through. Mark mentioned before about our value system and how those certain values can help boost our communications and get people to be more on board or persuaded to do something. We particularly found self-direction values worked well for this topic. And they're things like freedom, autonomy, informed choice. These were particularly powerful when talking about sexual and reproductive health. In fact, when we asked our audiences what government should prioritise in sexual and reproductive health, we gave them a list, and their top response was people's right to choose what happens to their bodies and health. That's a very autonomy, very self-direction sort of value that's at play there, and it's really important and front of mind to people. So this is a data point, and this is just an example of when we lent into self-direction a bit on the topic of abortion. We asked people to what extent do they agree or disagree that women have the right to make their own decisions about contraception, pregnancy and abortion without interference from others. Huge support for this overall. I think that was 86% people agree. It's very high. It was about a 10% boost from when we just asked a straight question about should abortion be legal and accessible, and just shows that how that sort of language can help you get a bit of a boost when talking about these issues. Also good news for anyone that's following it, I guess, works in abortion, that it is just such a topic that is still has such strong support in Australia, despite any of the political context in the rest of the world. So an example of how we could change our framing to lean into some self-direction language and really, utilise this value. We can go from saying access to sexual and reproductive health care is a right to saying everyone should be free to choose the sexual and reproductive health services and supports that are right for them. All right, I've got one more tip that I want to get through, and this is that you can use a health frame for sexual and reproductive health topics. This particular tip came from a discussion we had early on in the project as to whether people see sexual and reproductive health as part of health and well-being. Do they understand what we mean when we say sexual and reproductive health? Do they think it's important? Do they think it's important compared to other areas of health? And I guess the good news is, yes, people do really understand sexual and reproductive health. They can, in the focus groups, we asked people to explain it, and they were able to give us some really solid examples. Anytime we asked sexual and reproductive health questions or topics using health framing, so talking about it as a part of our health and wellbeing and the benefits of good health, it just seemed to make sense and it worked. So I'll show you a couple of data points. When we asked whether people agreed that sex that is safe and enjoyable is an important part of health and wellbeing, 88% of people agreed. That's very high. It makes sense. This was a really interesting one. Sometimes we like to throw our participants oppositional questions, so framed in an oppositional mindset. And again, we were concerned that maybe people thought other areas of health were more important, or this was just women's issues and not important for others. But when we asked people whether they agreed that issues like sexual health, fertility, and contraception are less important than other health issues, they fundamentally disagreed. So again, good news, only 17% disagreed. Yeah, and even in a question like that, we're inviting a comparison. It's very easy to agree with it. It's not, yeah, it's a tricky frame there. So that was really positive for us to see that people reject those sorts of ideas. And we did ask another one, I don't have the data point for it, but about that it's just women's issues, and it flopped. So people really see it as a fundamental part of our health and wellbeing, which is great. The last thing I do want to say there, and then I'll wrap up, is health framing is important, but remember to keep it down to earth, because if something feels too clinical or medicalized, they didn't like it. So health is different to medical, and we can lean into that. All right, I'm going to stop my share now, and I think we'll go into the Q&A.
Thank you, Kate, and thank you, Mark. There's so much interesting information and insights into all of that research, and I know that the top tips are going to be really helpful for people to use going forward. I'm going to introduce Shannon Hill from Women's Health Grampians, who's also going to be answering questions that anyone might have. I saw that, Mark, you responded to a couple in the Q&A chat. I'll leave them for people to read, and I might just go to the chat because I know there was a question. So question from Chris, I'll put this to Common Cause. What was the question you asked to determine the demographics and group the respondents into enthusiasts, persuadables, and resistors?
I'll take this one because I saw that earlier and prepared. So we ask a whole bunch of questions. It's not just a single question. And what we do is we effectively analyze the entire results of the survey by certain key questions that we've asked throughout it. So in this case, with this research, there were 16 of the questions in our survey that we used as markers of whether someone was a supporter or an opposition in terms of the old language or a persuadable person. And they ranged that we focused exclusively on questions around people's comfort with the topic and talking about it and so on. So for example, sex that is safe and enjoyable is an important part of health and well-being. If people strongly agreed with that, they got 2 points. If they agreed with it, they got 1 point. If they disagreed with it, they got -1 point, strongly disagreed -2, and so on. And other sort of questions were, I feel comfortable talking about periods, fertility, and menopause with friends or family. I would feel comfortable seeking healthcare if I was experiencing pain or discomfort during sex. Sex is a personal topic that should only be discussed privately, and so on. And the one topic that we avoided using as a classifier was anything around abortion, because we were interested to see how support or opposition to abortion as a more political issue fell naturally between those groups. And yeah, we did find a very strong correlation with our supporters being far more supportive or sort of people who are comfortable feeling more supportive of abortion, and people who are more resistant being opposed to abortion, or more likely to be opposed to abortion. But yeah, those were sort of the types of questions that we asked. And then we score people based on their responses overall, and then that gives us an indication of where they lie on that spectrum.
Thanks, Mark. I hope that answers your question, Chris. Got another question in the chat from Katie. I'll put this to everyone. How do you decide which message or tip to use? Is it based on the target audience or the situation or channel? I have a feeling that this, please correct me if I'm wrong, Katie, but I have a feeling this was when we were doing the message testing.
Yeah, so I suppose in general, what we'd say is all of these tips are provided in the guide because whenever we did any of those things, we saw an increase in support or we saw increased levels of comfort among people. And so the more that you can do more of the time, the better. And some are going to be more relevant in some contexts than others. So you would use the ones that are relevant. I think that's the only way I can really answer that, other than say as much as you can in as many circumstances as possible.
And just to add to that, I do think if something doesn't quite feel right, I mean, you know your audience best, and particularly if it's a community, we went so broad that it was nationally representative, which meant, of course, we were going to miss out on some specific nuances. So it points you in the right direction, but ultimately, you know your audience best. And if you really want to know a bit more, run a focus group and test it out and see if it flops, or if you need to tone it down a little bit or dial it up. Yeah, I think there you can play with it a little bit. It's also, I mean, when we sit down and we write these messages, it can be really hard to try and fit all those top tips and follow this narrative structure and do this in a social media post. You know, it's in practical senses, it can be hard. So I think you can lean into tips in different ways and pick out what you think is going to work or something you want to try. Some are easier than others. I think you can try moving a sort of myth busting piece into trying to highlight what are the positive things you want to see rather than the negative things you want less of. That's a really easy one to implement, but yeah, I don't think you can sort of sit down and put them all into practice for every audience on every piece. It's I guess just a guide for us as experts as well to figure out what we lean into and what we save for another day or take on note.
I was thinking about that too, Sarah, about when we're using it, we could be using it in written responses. It could be a campaign, it could be short form, it could be in workshops. So we're thinking of the broad uses of all the communication that we do. So we're really happy that we've got such a range of things that we can draw on, and knowing that it's going to stretch our brains to work and to practice this as a skill, but really excited about the opportunity. You know, what Mark said at the beginning really stuck with me about when we when we sit in the stigma and we ignore what feels wrong, you know, we've got this opportunity to use these techniques to shift people to what feels right. And I think that's pretty exciting.
Yeah, I'm just going to add to that. I think for me, with reading this guide, it is sort of drawing on each of those tips in like as a collective, and it might be a little bit of one in one situation, and just sort of building and developing the skills of communication, whether that's in-person conversations or if it's for social media or a report. I think I've just sort of been, as we've been developing these, I've just sort of been pulling from each of them in different contexts and just noticing. It's been interesting to notice when they come up. Okay, I have a question from John. So as we mentioned, the trans and gender diverse participants weren't captured in this research, and will we be seeking out trans and gender diverse respondents in future?
I can probably take that. It's something that we would love to do. So given the opportunity, the right group, the right perhaps partnership, it's something we would love to do. And Common Cause were amazing to give us a template for that to be included in the guide. So really that's something that we would be looking forward to do in future, not yet planned, but we'd love to look for the right opportunity to do that.
One quick note as well, because you know it was a limitation that we didn't pick up on that that audience. It did come up in the focus groups. There were some people that made it really clear, you know, SRH is inclusive, and they asked, what about non-binary folk and those sorts of things. So there was that association there, and it did get raised as a topic, and I thought that was interesting and important to note back on.
Okay. And following on from that, there's another question asking how we consider the experiences of minority populations, such as LGBTIQ people, people with disability, or culturally and linguistically diverse communities in our messaging strategy. Do we see the findings as broadly applicable, or are there areas that might need more tailored approaches?
Yeah, so one of the things that we did, so because this was a nationally representative survey, but also, well, a relatively small group, we sometimes have much larger samples where the budget allows. There were certain groups where we do have statistically significant information on, and others that we don't. And where we had that information, we absolutely considered that and looked at those variables. So, for example, we had probably below the threshold for LGBTQI plus people, but people with a disability probably fell into the acceptable range of numbers for us to then be able to generate responses. And across the messaging strategies in terms of what works and what doesn't, we did not, among those that we had enough data on, we did not notice any big variance in terms of, in other words, in short, what we think works for all the groups on which we had sufficient data. We didn't notice any major anomalies to that.
I can talk through, I've just got some of the stats up on screen. I noticed there's another question in the webinar chat about demographic differences. I can reel off a couple of top line ones to answer any of those burning questions. Women were slightly more likely than men to be enthusiasts and less likely to be resistors. People who were born overseas or spoke a language other than English as their first language were slightly less likely to be enthusiasts and more likely to be resistors. Greens and Labor Party voters more likely to be enthusiasts, quite notably, and more resistance among our coalition voters and even other minor parties. Small trends of increased comfort and enthusiasts amongst higher income households and education levels, and we tested that in further with the focus groups. As Mark mentioned before, there was a strong correlation between abortion stance and attitudinal groupings, anti-abortion or people who are unsure about abortion, significantly more likely to be resistors. And lastly, where we didn't see differences and where our tips, we're really confident to apply. People who identified as living with a disability or chronic health condition, no statistical differences across the board. No consistent differences amongst age groups or people that lived regionally or rurally. Age groups was an interesting one because people do, have different concerns, and we really found this in the focus groups that people shared the sort of, I guess, across the life cycle, this sense of SRH for all ages, which was really interesting. And yeah, we didn't have anything we can strongly report back on, but there were some small variations. And lastly, while we didn't have statistically enough people from LGBTQIA+, I think we had 79 in total of the study of 1,200, which isn't enough for us to say confidently, but there was a trend of quite notably more enthusiasts and less resistors. So they seemed more on board and were part of these, engaged in these sort of conversations, but we can't, the sample was too small for that. So I hope that answers some of those burning questions on demographics.
I think that the guide, we really see it as a start of a conversation too. So if you can see a group or a need, or we'd love to talk to you about how we use it. We want to be out in the world and talking about it. So be really happy to be talking to groups and partnerships about what to do next.
Great. Okay. Another question, a little bit, I think will be the last one on demographics. It's a question around how survey participants were sourced and if there were specific target audiences notable in enthusiasts, persuadables, or resistors. I actually feel like you've answered that question, Kate, and there is a bit more information in the guide around the data. So I'm not sure if you have anything else to add to that, but I think you answered that.
Maybe just quickly to the first part of the question is how were they sourced?
Yeah.
We source our respondents from a large commercial panel, one of the largest commercial panel in Australia, so that we can get the best, most randomized sample that we can for an online panel. So they are randomly randomly drawn into the survey without knowing the topic of the survey, which is really important, so that we don't have a kind of a bias in people who are interested in this subject responding and so on. And then what we do is we have certain quotas and targets around diversity of respondents to make sure that they are nationally representative. And our main focus from memory on this one was around nationally representative by gender, location, rurality, and age, and some interlocking age and gender quotas there as well. But then overall, we're looking for things like, do we have the proportion of First Nations people we expect? Do we have the proportion of LGBTQI plus people we'd expect, and so on?
And just to add, because I always find it interesting when we set up these surveys, we want to sort of try and get rid of dummy data or trick people into, sometimes people might sign up to a survey and put a certain demographic because they think it'll mean they're included and they get the incentivized for that participation. But we really plan it in certain ways to get a representative source that is authentic, and we do clean the data and things like that as well. So it does go through quite a notable process to get where we end up. And we have, I mean, the data is just spreadsheets full of stuff. We've really summarized and condensed it as much as possible. But I think, if there are any data nerds that really want to dive deep, I'm sure we can have a discussion about that as well.
I love the question about what was the most surprising in the research. And I think that for me in the data to not have a difference between rural and metro responses was really surprising. So that's something, an incredible thing for me to work on as a rural and regional worker. Was there anything else that you had as a surprising finding, Kate or Mark?
I do think on that note, in terms of, I guess the impact of location was really interesting. While we didn't have any notable trends at population level looking at that nationally representative data, the conversations within the focus groups themselves were really interesting. When we asked where you would go to seek services, some people really enthusiastically, reference their local community service, and they all have different names in different states, which is confusing. But some really spoke highly of that. Some in regional areas, others had no idea and would just Google it. And when we asked where would you go to, it was GPs and Google were, or your female friends were the main things, and that was interesting to see. The difference between and what it means to have a place locally where you can go to for these things compared to people that didn't. And I think that was interesting. And after doing this project, I would want to do a big communications piece about getting more people to their local services and, going to sexual and reproductive healthcare service websites and those sorts of things, because I think there's a gap in where people go to for their sources. So that's, I guess, not necessarily surprising from this project, but it got me excited on, oh my God, we need to do more. How can we get people to these sort of safe spaces or promote these sorts of things? So that was, I think that, I don't know if that was a surprising finding, but probably a surprising finding for me. I guess for me growing up in a house where this is a bit more uncomfortable. Like, I wouldn't talk about these things. I couldn't believe how on board most of the general public was. The level of overall support and interest and engagement, even in the meatier topics, was really high. And I think it was higher than I expected, also higher than we see in other health topics. So just that overall personal and professional reflection on how, I guess, interesting this is as a topic and how people do engage with it. That was a really cool finding.
And maybe on top of that, one of the interesting things for me, I don't know if it's surprising, but it was unexpected. I wasn't looking for it, but we found it was high level of support for, we need to talk more openly about this as a community. And then a reduction of support for, I want to talk about it personally, right? Someone should be talking about this stuff and we should be generally talking about it. Not quite sure I want it to be me. So that was an interesting thing there, that sort of, there's almost at a political level or at a societal level, we feel like this is important, but maybe people personally don't have that level of comfort. But then again, when we ran those focus groups with people, many of whom did have a personal discomfort about talking about these topics, once they're in that space, they launched into it and very, very happy and quite relieved and sort of, I don't know, excitedly having a conversation that normally they're not feel like they're able to have. So I think that was an interesting one to me. And I should say, just one other data point, Kate mentioned there was another question around men and their attitudes to women's issues and so on. The question in that I think she was referencing was a statement that said men do not need to know about women's issues like periods, fertility, and menopause. And I'm not particularly surprised because I'm always sort of pleasantly surprised by some of the things we see from men, but I think maybe some people might be, and that is that only 17% of men actually agreed with that statement. So the vast majority disagreed. More women disagreed than men, but you know, I think that was a pleasant finding.
Thank you. Okay, there's just a couple more questions. There's one that's asking, like, as a sexual and reproductive health relationships educator, it's not really easy to bring up some topics with different community. What is the safest way to go about this topic with older people?
Really interesting because I guess, and it always depends on your own community, but we didn't have a notable difference with older folk. In fact, our focus groups and the nationally representative data did actually show some positive signs of talking about those things. There was a really interesting conversation in one of the groups about how aged care homes, everyone's talking about sex. And I was like, great. So I wouldn't necessarily think that's always the case, but of course, you know your communities best. And I think one topic we really tested it on was sexual pleasure, which we know is a topic that some people love. Some people don't know why we're talking about it. Others don't like it. And I think you can lean into it gently, like not coming out guns blazing, talking about all this, you know, pleasure positive stuff and the language that we use in this sector, which is great. But I think, again, using that relatable everyday language, being more down to earth and those sorts of things, I think can help, and setting that sort of safe space and that tone first. And maybe those messages, you know, telling so-and-so who's very uncomfortable to talk about this, perhaps that's not the right tone. I think you can make that decision within a community. But overall, we found, yeah, no obvious red flags or major differences with older populations. So in a certain sense, you can have some confidence talking, you know, in quite an empowering way with some audiences that maybe you may have an assumption that maybe won't want to engage with it. Perhaps they will. So yeah, that's probably my thoughts there. I don't know if you've got anything else, Mark.
Maybe just that the topics that are relevant at different life cycles would be another way of engaging people. And we did find people like to see their experiences represented in the messaging. So that's sort of one of the tips that we have, is around making sure that you're giving lots of different examples across the life cycle that are relevant to people.
And people feel comfortable talking to other people that are in the same sort of boat, that have the same sorts of issues on the top of their mind as well. Like menopause was one that just went off in some groups where that was a really relevant topic as well. So that's probably good advice to tailor the topic. And yeah.
Great suggestions. We also have a question asking if there's any advice for engaging opposition.
I mean, Mark, I'm happy if you want to take this one. I guess, do we mean by opposition people that are uncomfortable, or I guess our resistors, or people that fundamentally at a policy level don't agree with, you know, sexual and reproductive health, opening up access, abortion, those sorts of things? So I might speak to, potentially, if we're talking about that more policy side and people that are, you know, don't like women and those sorts of horrible things. And one, I guess, a piece of advice we often give at Common Cause is not to feed the frame, not feed their language and put more attention and, you know, get really angry and, you know, tell them why they're wrong and put that out in our communications, because we are unintentionally drawing attention to that space. It is hard because we know that while most people are on board or supporters or you know, agree in principle with a lot of things that we do in policy in the women's health sector, even if they're not engaged. Most people in the general population do, you know, agree and support women's rights in this sector. But it is a loud, vocal minority, and that's always the problem. That's who you might see in your social media comments. They're the people that stand outside abortion centres, and that's really intimidating. And I guess from a communications perspective, it's just not making that bigger than it is, and not feeding that frame and jumping into the way of they're talking about it to focus on our strengths. Mark probably has some more tips on that.
No, just I suppose if the question is meant from the other perspective of if we're talking about the sort of the people that feel the most hesitant talking about this, then I suppose one thing I'd question I'd fire back is why? Why are we focusing our time and energy on them, given that we've got 70% of the population who are persuadable, which means that there's work to be done, right? They're not already on board. They need to be brought on board. And it's rarely the best time of our use or resources to focus on the people that are the most resistant when there's a whole bunch of people that we could be spending time with more productively. But at the same time, there are instances, there are times when, for some reason or other, our audience happens to be the most resistant, in which case you're going to really, really struggle is the short answer. But it's not impossible. And it is about, I don't think there's a message that does it, right? I think when it comes to those really, really sort of crusted on resistors, it is a matter of more longer term two-way dialogue than thinking that we've got some sort of clever spin that we can use to bring them on board. Persuadable people are persuaded by different types of messaging. Those sort of resistant people are not really persuaded by messaging. So it's something else. It's deeper engagement.
One extra point I just thought of is the kind of oppositional frame that was the most effective with persuadables was this frame about privacy and private. This is a private issue, which, yes, there's some good things about us saying, right to privacy and those sorts of things. There's so many different ways we can talk about privacy, but it was, I guess, the frame we'd be most wary of, because if we talked about SRH as a private issue, it could really feed that frame of, we don't talk about this, it's not in our public sphere. It was just the most convincing frame for our persuadables. They didn't really engage with those anti sort of policy ones, but when we talked about, private, not in community or those things, we did lose some persuadables. So that is the particular frame I would be wary of not overfeeding or getting too caught up in a online heated debate about it. So I guess when we think about these topics, and again, I'm picturing it in an online debate or something, we've got to think about what our persuadables will see and where they will go to from there, not necessarily what our opponents will do, because we can't win them. But yeah, thinking about that and privacy is the one, and private issue was the one curveball I think we had with this project that we wanted to not feed too much.
So interesting. But I think we actually only have time for one more question. I'm going to ask the one that says, what do you see as the next logical way to extend or build from this research?
I think from a women's health perspective is it's for us to learn to build our skill, to build our capacity, to stretch ourselves and the way that we think about how we communicate, and then by extension, spreading that out through our partners and connections and networks in our region. So for us, that's very much front of mind in thinking about how we work with the guide now. I think the work for us starts now, and we build on what we've been given by Common Cause in such a brilliant guide and a practical thing that we can use.
Thanks, Shannon. Was there anything you wanted to add, Kate or Mark?
The only thing, and I think we've covered it, if we had more, I guess, funding time, all those sorts of things, we'd love to dig into some priority populations. And we went so broad with this in this topic, which was great, but there are so many subtopics and priority populations that you could get some more intense and usable findings for. I will quickly note, for some that do work in different topics, we did collate a list of other guides that are available. Not much work has been done in this sort of level of depth, but there are some other topics that you could point to and apply. But yeah, if I had, endless funding and endless time, I'd be going and looking at different topics and different communities and getting some really actionable tips and wording for certain subtopics that might be some winning frames.
Amazing. There's a handful more questions which are super interesting, but rather than answering them in this webinar, I think what I will do is encourage people to get in contact with the Victorian Women's Health Services Network to see how we can use this guide and further work with working with different communities and applying it to your work and unpacking the guide a little bit more. So yeah, please don't think that those questions are going to be unanswered. There will be more opportunity and hopefully more conversation. This guide is just sort of that starting point to get us thinking. All right, I think we'll wrap up the Q&A there. Just a little bit of a summary on what's next. So as I mentioned, the guide will be emailed to everyone that registered today. It's also available via this QR code. We really encourage everyone to take time to read the guide. We're hoping that this is something that is going to be a practical tool that you can use in your everyday work. So have a read, print it out, have it at your desk, and have it as something that is there as a reminder. And the tips will sort of come through in your work. And if you do want to have more conversations around this, please, if you're in Victoria, contact your local Women's Health Service. And what we would encourage you to do is, as you're reading this, consider whether you might benefit from training or capacity building on how to implement and understand the guide, or maybe a peer learning or discussion space, or if there's tools that you're wanting for working with specific populations. I know some of that did come up in the questions in the chat, and we're really, really eager to have those conversations and support you with that, and also to learn from the questions that you have in the different spaces that you work in. So yes, please have a read, share the guide as far and wide as you can. That would be great. And we do have an evaluation link. We'd really appreciate you taking just a couple of minutes to reflect on what resonated with you in this session, and to hear from you with some of those responses to those prompts of where you might like to go with next and how we can continue to develop this work. The evaluation link will have a spot for you to pop in some further thoughts. So please take the time, and we'll leave it there. I just want to say a huge thank you again to everyone for taking the time out in their day, and we look forward to working with you on it further.